Good morning. Welcome to the clinical meeting. So today, on behalf of the Department of Medicine, we are thankful to Dr. Ramya for having given Medicine 2 and Clinical Epidemiology Unit the opportunity to present on behalf of our department. So today's presentations will be by Dr. Jahnawi and Dr. Sakshi. This is on a qualitative study that they had done as a part of their PG thesis on perspectives on healthcare, the patient's caregiver's perspective as well as the healthcare provider's perspective. And a similar sort of study was done during the period of Professor Kurien Thomas, sir. So we thought we could have no better person than sir to chair this session. And thank you very much, sir, for having come to moderate this session. Extremely thankful. And I'm also thankful to our online participants as well, and our special invitees, Professor J.V. Peter, sir, who has kindly joined online via Zoom to provide sir's comments. And my special thanks to our special invitee, Dr. Kishore Pichamuthu, sir. Thank you very much, sir, for having come today. And also, we think that there will be a few more online dignitaries who will be joining online as well to give their feedback. So without further delay, I'll hand over to the speakers and the chairperson for the session. Thank you so much, sir.
It's always a great pleasure to come back to CMC and be part of a scientific meeting in the Department of Medicine. I think it is, you have both completed your MD, no? It's a very great pleasure to have two PGs having done. Previously, the qualitative studies were perhaps not very much common in CMC. I went through your studies, and I think it has been done pretty well. So I'm glad that we are looking at both quantitative and qualitative aspects of science and how to approach it. I have the long time ago, about 2012, I think we did that study. It's very important that how can we improve the care in the intensive care unit, because it is a very the issue is how can we the issue. I think you will bring it up very well in your. There are many issues there, but it's a extremely short supply and high demand area, and extremely costly. So how can we improve the efficiency and the quality, and keep it as efficient as possible are the three main challenges I think you have addressed. And I welcome both of you. And who is presenting first? Please come forward.
Good morning, everyone. So before beginning, I would like to thank Dr. Tambu, Dr. Shubha, and Dr. Rani, who helped me and came up with this idea of the study and helped us through the process of going through the study. So what we were looking at was quality of care in medical intensive care units, which was both perceptions of the family caregivers whose patients were admitted into the ICU and doctors and nurses who dealt with such patients. Why we felt the need for the study, I would want to go through the justification, how we went about doing the studies, and what was the resultant conclusion that we do from the study. So coming to why the study was done, shocking statistics that I found out when I was reviewing literature was that 15% of mortality in low and middle income countries, according to WHO, is because of poor quality of care. And although there are multiple quantitative scores that assess this quality of care, in the current modern scenario where patient satisfaction is coming up as a major tool for assessing the quality of care and their satisfaction, a perception of care, which is beliefs and opinions of stakeholders based on the experience in the healthcare setup, is now a major yardstick to assess the quality of healthcare. Despite this thing, we do not have adequate literature, especially from the healthcare provider side, to assess what they feel about the challenges and their roles in providing adequate quality of medical care, medical ICUs. So this is why we went ahead to do the study. We also had a similar study done in 2012, which was Q-tip study, assessing the quality of care in ICU. However, that was done only from the point of the caregivers. So we felt the need to also address the healthcare providers here through this study. So the objectives of the study were to gain better insight into the experiences and challenges faced by the caregivers once their family member was admitted into the ICU, to explore the experiences, beliefs, and opinions of doctors and their challenges while providing adequate quality of care, and to understand the role of nurses and what they felt about their challenges during the course of providing care. So how was the study was done through a qualitative methodology where, based on previous literature review, we came up with a conceptual framework. This conceptual framework is basically the points that we identified from literature search that had come in previous studies as major factors in experiencing and providing quality healthcare. Once we drew this conceptual framework, we made interview guides and focus group discussion guides to assist us in taking the interviews for the participants. So when we decided who to interview, we had looked at 3 stakeholder groups that were important in assessing the quality of care. The first was caregivers of the family members who were admitted into the ICU. Second was doctors, both from the unit who were admitting the patient into the ICU and the doctors taking care of the patient from the intensive care side, and nurses who are working and providing care to such patients. So based on the inclusion and exclusion criteria, we chose patients who were admitted at least for 48 hours into the ICU, and we took their caregivers. After their consent, we included them into the study. We chose 10 doctors, which was purposive sampling to ensure that we had diversity in the level of the doctors and from both ICU and unit side. And we took 9 nurses for the focus group discussion. Once we conducted in-depth interviews for the doctors and for the patient caregivers, and a focus group discussion for the nurses, we did what is called 6 steps of thematic analysis, which is through the process of data immersion, transcription, reiterating and reading the data multiple times, and forming codes. So once we formed some codes from the first 3 interviews that we transcribed, we used that code book to transcribe further interviews to see where we got major themes that were emerging from the study. So after collection of data, we used the NVivo software to transcribe these files and then come up with the themes. Now, what were the results that we found? So before going that, the baseline characters that we had were 10 doctors. 2 were postgraduate residents, 2 were parent unit consultants who admitted the patients into ICU, 5 were ICU senior residents, and 1 was ICU senior consultant. Average duration of the interview was around 32 minutes for the doctors. We conducted 1 focus group discussion with 9 nurses of various stages of their practice, which lasted for 1 hour 32 minutes. And we took 10 patient caregivers. So this patient caregivers was selected also purposively to ensure that we had patients with different prognosis, different illnesses, different age groups, and different socioeconomic strata. So we chose around, out of the 10 patient caregivers that we selected, 7 were male, and the average age of them was around 36 years. The diagnosis of the patients who were included into ICU, who we included in the study, included snake venomation, infections, and organophosphorus poisonings. So coming to the themes of analysis that we identified through our study, first was skilled medical care and adequate resources. Second was healthcare worker and patient caregiver communication. Third was teamwork and communication among the healthcare workers. Fourth was medical decision making. And fifth was cost of care and financial aspects. So I would like to highlight each of these themes that had emerged. And we will go through how a qualitative data is also presented in views of how the codes had come up and what codes substantiated our conclusions. So when we came to skilled medical care and adequate resources, most caregivers thought that excellence of care is the utmost importance that brings them to a hospital. They wanted skilled care, and they, based on how the perception of hospital is outside, they bring patients to a hospital. Doctors thought that skilled medical care, adequate staffing in terms of both doctors and paramedical staff, good technical instruments, and adequate spacing helped them provide a good medical care. Nurses believed that their role in providing good medical care was doing their responsibilities well, which included maintaining asepsis, administrating the medications on time, and ensuring that the overall ICU running was smooth. There were multiple shortcomings that were highlighted in this aspect. One was doctors commented that sometimes the space surrounding the bed is not adequate for them to do their procedures adequately, and they would like more space around each bed in the ICU. Nurses identified that they had very long working hours, which prevented them to give their full to the patient care, and also that there was shortage of staffing for them. So I would like to highlight some quotes that had come up in this aspect. So one of the caregivers said, despite so many difficulties and emergencies, we bring the patient so far because all of the feedback we get from here, and the hospital is so good that they can bring back even a dying patient. One of the nurses said that without food, shelter, rest room, and asking them, this is in terms of patient caregivers, to sleep on the floor means it's very difficult for them. They have to take care of the patients, look after themselves, and during that they cannot do this, and therefore they are spoiling their own health, highlighting the need for better waiting facilities for patient caregivers who are admitted in the ICU. I think that has been addressed in significant terms with the Ranipet ICU that has come up, and there's better waiting facility, but I think in our setting it's still lacking, and this is something that we can look at. Coming to the next theme that had come up, which is healthcare worker and caregiver communication. So according to family members, they thought that effective communication was the cornerstone of their relationship with the doctors. And if the communication was frequent, transparent, and regular, they thought that that helped increase the trust in the doctors and the treatment that was being given. And it allayed their anxieties as well. According to frequency, they thought that once a day communication with a senior doctor was not enough, and maybe twice daily, morning and evening, would help them feel better. And they also encountered significant problems in terms of language barriers, because we have patients coming from all over the country. A lot of caregivers thought that their language was a problem. Some doctors they encountered, they thought they were not talking in layman terms, and that medical language was being used more often, which hampered their understanding of what the patient has. They also thought that the visiting hours in ICU was not adequate, and they would want to see their loved ones more often or for a longer duration of time rather than the current setting. Most of the caregivers that we interviewed really appreciated having a social worker in the team, because that was something that they thought was unique in our setting. And they felt, some caregivers quoted that they felt that the social worker was part of their family, and they talked to them so much so that they felt at ease with social worker much more than the doctors sometimes. So this is a quote where one of the caregivers, on being asked whether they want to know just the overall view of the patient status or details about their condition, they thought that they would like to know the complete truth with all the facts. And it is good to keep transparency, because if someone becomes serious later in the future, it will become even more difficult to grasp later. Another caregiver mentioned that there's nothing called a social worker in any of the other hospitals that they had seen. And they felt that the social worker was very, very supportive, and they felt that they had known her for many years. So I thought this was something that was very positive in our ICU setting, which was something that we could help others also inculcate. Coming to what healthcare workers thought about the communication, a lot of doctors felt stressed because to have regular communications because of the busy schedule, and because of the fact that sometimes when they go to have communications, especially from the unit side, that the family members are not there. So it's difficult to meet the family members and have communication with them. They all stressed on having very, very honest, transparent, and lucid conversations. And they thought that the conversation should happen at a dedicated separate area and not in bedside, to ensure that they can have proper long conversations. again, daily interactions with a senior doctor was stressed upon to have a better relationship with the patient caregiver. So one of the doctors said that, to my understanding, always looking at a holistic patient care, along with making sure that the patient bystanders and relatives are also very well informed and communicated, allayed the anxiety and overall improved care. Another doctor mentioned that sometimes it's difficult for them to communicate with relatives because the primary relative who's in contact changes. So one day they have to explain it to a relative, and the other day another relative is there who they have to explain to. So they would like to have one person who they can contact each day to ensure that they can keep updating instead of having the conversations from the beginning, to ensure continuity of communication as well. Challenges faced both by nurses and doctors, again highlighted language barriers is one of them, frequent changing in the family members, assuming the role of the primary caregiver, and occasional lack of understanding in the caregivers, which prevented them from explaining the condition of the patient properly. Something that the nurses pointed out was they were not allowed to give medical information or updates about the patient to the relatives, which they thought was hampering them, because a lot of times relatives would come and ask them how the patient is doing when they would interact with them for procedures, for shifting the patient, to give the medication slips and all. However, they did highlight that because apart from that, they really helped in the spiritual and logistical issues with the patient. One of the nurses said that they will ask the patient caregivers if they've eaten or not, if they have adequate money or not. And sometimes if they feel that the patient provider is not being taken well care of, they will bring it to the notice of the doctor to ensure that they can be helped if monetary issues is a problem. One of the doctors highlighted saying the biggest barrier for him was often language issues. And as much as they try, there's nothing like explaining to the patient in their own language. So that is something that they felt was difficult for them to provide adequate, good communication. Coming to our next theme that had come up, which was teamwork among healthcare workers. Most of the doctors that we interviewed stressed on the importance that openness and communication at all levels, mutual respect among different, because ICU is a place where multiple teams come in and give their input, mutual respect for each doctors and for their opinions, and positive criticism, positive feedback or discussions was the most important thing in giving good medical care to the patient. This was especially because our ICU is a semi-open ICU structure. They felt that it was very important, and most of the doctors felt that they had that stage where their communication was free and they were mutually respected. However, when we came to nurses, most of the nurses felt that there was some problem with the doctors, especially at the junior level, where they thought that doctors were often condescending. Despite the years of experience that nurses had in ICU care, especially new trainees who joined the ICU often did not respect them enough that they would like that part to change. They also highlighted that their interaction with housekeeping staff and attending staff was very difficult. Often they would not get the required help that they would like in giving patient daily care, which they thought may be something that could be worked upon to improve the ICU work. So one of the nurses said that we have to talk to them nicely and often coax them into helping us with the work. That is part of their job. And we cannot use any harsh words. We cannot say orderingly. To do their routine activities, they have to coax the hospital housekeeping staff sometimes to help them. One of the doctors said that I think trust is the basis of working in an ICU environment. And over a long period of time, you will trust each other's judgment and respect each other's opinion to ensure that the teamwork that is there in the ICU, which is one of the major pillars of work, will keep going. When it came to medical decision making, both doctors and caregivers considered that the caregivers are the primary decision makers when it came to making medical decision, where the role of the doctors only came up as facilitators. So where doctors can guide the caregivers and explain the prognosis, but the primary decision making lay in the hands of the patient caregivers. When it came to what was the important factors that both doctors and caregivers considered, where doctors considered the age of the patient, the reversibility of the illness, and the cost of the care involved, most caregivers were emotionally weigh emotionally when taking the decisions about major medical decisions like end of life care or how to the extent of continuation of care. So where one doctor said that the two things that they feel should be more stressed is the cost and the quality at the end of it. So one is whether at the end of doing all this, at the end of selling all the lands and all their resources, if they're actually going to get a patient who's even conscious at the end of it, highlighting the concept that prognosis and quality of life comes at the foremost for doctors when it came to decision making. Whereas the caregiver said that honestly, at that point in time, they don't think a lot. They just at that moment want to recover the patient. They do not process the ifs and buts. They do not do any calculations. They do not run algorithms. They just take the decision of admitting the patient for the best possible treatment. Coming to cost of care and other financial aspects. So considering the facilities provided, most doctors and nurses consider the ICU care reasonable in our institution. So someone has quoted that we should be charging based on the bed and nursing that needs to be charged. It's much, much less in comparison to the care that's given here because because ICUs actually costed it. And it's about 5,000 to 10,000 less than the actual costings that go into the care. So the cost of ICU here is for the intensity of monitoring, the top-notch equipment, and the ventilatory support. And they thought the pricing was reasonable. However, caregivers thought that it was a huge burden to them because the spiraling costs and the huge bills often ended up them having to sell their land or pawn their resources. What they highlighted was if a clear financial plan was given to them beforehand at the time of admission and regular updated bills were given to them, they would have better chance of mobilizing their resources to pay the bills. When it came to subsidized care, most of the doctors and patients agreed that there is that facility and they are happy to avail of that. And it should be based on prognosis and the social strata of the patient who is admitted with the ICU. So where do our findings stand in terms of what has already been done previously and what is the current available literature? So when it came to areas of alignment, our study had similar findings in terms of importance of competency and good outcome, which was highlighted in multiple other studies, need for effective communication, teamwork in intensive care, which is a pillar of good care, and burden of ICU costs as experienced by the family caregivers. However, things that came up uniquely in our study, one was the implicit trust in the institution, which we did not find in other papers that had looked into the similar patient caregiver perspective. Second is language and cultural barriers in communication. I think because we have patients coming from all over India, this is something that's very unique to our setting. And because of that, because of different languages that are used, it's a barrier also in communication. Doctors' role as facilitators in decision making. So even our QTIP study that was done in 2012 and based on some other Southeast Asian studies that we had looked at, most of them said that it was mostly a shared decision making where doctors took the decision and patients generally followed that decision. But however, in our study, it came as although the doctors were major facilitators in decision making, it was primarily the caregiver who took that decision finally. And finally, challenges in healthcare worker relationship where there was a disparity where doctors felt that their work environment was very good in terms of communication and teamwork. However, nurses did not say the same thing. So that is something that we should keep in mind. So concluding, I would think caregivers believed in skilled doctors, were mostly satisfied with the clarity, comprehension, and transparency of communication with them, and considered that the final medical decision-making lay in their own hands. Doctors identified proficiency at work, effective communication with the healthcare, with the primary caregivers, and good teamwork as the cornerstones of good intensive care. They expressed challenges in terms of language barrier and busy schedules to facilitate good communication and adequate quality of care. And despite addressing challenges with respect to long working hours, shortage of staff, and sometimes not a good working environment, nurses exuded pride in the execution of their daily work with integrity, which they thought was paramount in providing quality care. So how do we move forward from this study? Some of the suggestions that I would like to give is One is implementing communication training for especially new doctors who join our setting, where they can be highlighted to work on clarity, on the empathy and effective communication. Second is to improve facilities, especially for caregivers who wait outside. So if their waiting facilities could be improved, providing them with water or accommodation may be a way forward. Third is to address staffing issues and reduce workload, both for the nurses and doctors, in terms of either making the hours of their shifts shorter or in recruiting more staff. Third is promoting teamwork. This was especially for nurses where they felt that their work environment could be better. So to encourage open communication and mutual respect among the team. Third is financial transparency, so to maybe give a detailed care plan, a detailed financial plan at the onset of admission, which we do mostly, but maybe breaking it down further for them, and to give them regular updated bills ever so often, so they can understand that where the bill is happening and to mobilize resources. And lastly, I would also want to think maybe a longer duration study to see the effect of admission of a relative into ICU, how that takes a toll on the patient caregiver, the primary caregiver, who is the primary person for communication and taking care of the patient. Thank you.
That was an excellent. Can you hear? That was an excellent presentation. Congratulations. So I just want to raise two issues. One is a methodological issue. Even though how many focus group discussions were done? You
Only one, sir. Yes,
See,
sir.
there is an issue there, because validity of qualitative study also depends on the minimum number that is required to do. I suppose for practical purpose, as you as a PG thesis, etc., you may not have found time. But on an, I think if you, I think there will be, who are the qualitative people here? Tambu?
It's the point of saturation, sir. They hear the same ideas.
No, what, see, the stakeholder identification, and then stakeholders has to be grouped into at least a group of for example, if patients may be very similar, but health providers and administrators may have different perspectives. So generally, I would say at least three focus group discussions. They may have the same outcome, but that then validates the issue. But if they can have different outcomes, I mean, that's one limitation that I find, but that's all right. But within that limitations, we have done very excellently. So the other issue is regarding how do we make the decision making? Certainly, it has to be done by the caregivers. But can health providers, because there is a conflict of interest here, their own interest is on one side, they will go into poverty. On the other side, they expect good care. And therefore, we have to use some scientific method to balance which is the best way forward. We are not going to make an absolute decision and say, you go out, but you have to help the caregivers make the decision. Their emotional point at that point is not easy for them to make it. So to say that finally health providers will make a decision and the other people will stand by is perhaps wrong. So it has to be a combined decision making where the knowledgeable or understand with less emotional interaction come and says, this is perhaps the best way forward for you. So I don't think it is either one or the other. It has to be a combined decision.
Basically, what I wanted to highlight from that was when we did the previous study in 2012, the quotes that had suggested was that mostly they would follow whatever the healthcare provider said and guided them. But here, what we found a difference was the relatives said they would want to take the decision with the doctors as the facilitators.
No, I think there's some time for discussions. Anybody wants to ask a question or clarification, please come forward.
So we just thought we'll do the study because the previous study, we had only interviewed the patients and we had not got the feedback from nurses and doctors. So we built on the previous study and we decided.
Doctors were there.
Yes, sir, they were. So the other thing is, to get all the nurses separately is difficult during time. So that's why we said one single focus group of the nurses together. It was a practical issue during the postgraduate time. And it was also, I think, the first qualitative study from our department is PG thesis, Sakshi and Jahnawi.
Very good.
They went for the course with Dr. Shubha, then they did the interviews, they transcribed it, they learned to do coding and writing and all that. So they really took a lot of effort. So
Excellent.
again, thanks to you, so you inspired us to do the first study. So this was a takeoff from that. That is the comment.
Anybody else want to ask anything? Any clarification on the issues?
Yes, ma'am. So we, from based on previous literature review, what we thought was when we conduct in-depth interviews, mostly by the 9th, 10th interview is when thematic saturation is reached, which we also found in our studies. By actually the 6th interview, we reached thematic saturation, and most of them reiterated the same thoughts after that.
And with the focus group, it was with the nurses that you did the focus.
Yes, ma'am. So there were 9 nurses from the ICU of all cadres. So there were senior nurses as well, nurses who were doing their bond, which we thought may have been a limitation because they may not have been open about their ideas. So that one we thought was a limitation in our study, but because it was COVID time, we didn't have the space to call all of them separately as well.
Zoom meetings, senior separately, junior separately, may have given you a little more of the valid ideas.
There are two issues here. One is an in-depth interview. I think in-depth interview, 9 people is fair enough. I don't think you're going to get much more out of more people in in-depth. But focus group, there's interaction.
Yeah.
So the focus groups can come up with different perspectives when you interact with each other. So that is an area which you could have umbrella. But I think agree, postgraduates have got limitations in their time. Thank you.
What about patients? You did in-depth interviews with
with the patient caregivers, ma'am, not the patient.
You reached the point
Yes,
of saturation. Did you happen to interview? I'm sorry, because it's in the intensive care setting. There are lots of other teams, right? There's a respiratory therapist. There is a perfusionist, meaning I think they will know. The critical care therapist.
No,
So
ma'am,
any of those alternate allied health groups there?
No, ma'am, we've not interviewed them.
Okay. So there's actually more scope in a way to see what. What about the social worker? Did you interview them?
No, ma'am.
No,
because there was only
That might
one
be a
social
critical
worker.
call.
So
Okay, now there's a team.
okay,
So perhaps,
fine.
yeah. Fair enough. Thank you very much. Lovely work.
Thank you.
Right.
Ma'am.
Okay. I think anybody else?
Good morning, ma'am. Ma'am, sometimes I've seen in ICU that we preemptively ask the relatives to get that DAMA and DNR form signed. How big an impact does it have on the decision that a healthcare provider makes in this?
So we had not explored that part of the thing because it did not come up in the interview guide. But most of the relatives and the doctors, once the patient gets admitted into the ICU, on the first day they talked about how they had a detailed conversation with all the family members. They sat down and they got the background history of the patient, where they are coming from, what they are looking at, and their expectations. And only based on that, they will come up with the decision of what is the extent of care. So I don't I mean, we not look into it specifically, but from my understanding, they had that discussion all over again and did not base the decision just on what the signature was taken in either emergency or the ward.
Just a clarification, Tambu. What are we following the utility assessment on day 2 to make a decision on regarding the cost and care?
So we are doing the utility score on day 2. That's part of a set. Along with her, Renju, another postgraduate, did the costing. So we put that separately. So that's going to be for another one. Yeah. But actually, the doctors instinctively say a sort of score like that.
Yeah.
But so we are using that data, but we're presenting that as a separate.
Okay. Right.
Thank you so much, sir.
Yeah. This 1 minute. Some online comments on it, please.
Sir, I think JVP sir is online. Sir, do you have any comments or questions, sir?
Thanks, Vignesh. Very nicely done study. Yes, thank you, Dr. Kurien, for introducing us to this world of qualitative
Sound is not coming,
studies.
JVP.
Can you hear me now? No?
It's not connecting.
Can you hear me? I don't think they can hear in the auditor and in the hall.
You can type your comments, JVP. Type it so somebody can read it out.
I think there is some online issue, but there is one comment. I'm surprised that nurses said that they have long working hours when their working time is fixed. It seems to be a comment.
I don't know whether it's a comment. I think it is perhaps not. You cannot answer that.
Yeah.
That's what we found from our study, so that most of them thought that number of hours was long.
Essentially, are they asked to work extra time, or it's just that period is finding to be too much? Is it?
Yes, sir. The thing after that also, the handing over and the taking over sometimes take time, but
yeah, he can hear.
Sir, JVP, sir.
Yeah, all right. So let us go to that. I think because of the technical issues, can we move ahead and then call back at the end of it again once more? Okay.
Yes.
Good morning, everyone. I think Sakshi has given a little bit of introduction already about why we look at perspectives of the healthcare providers in addition to the patient and the patient caregivers in the setting of ICU. So this is my study, which is titled Qualitative Study. This is perception of the aspects and quality of healthcare amongst the patients and the healthcare providers, which includes doctors and nurses in the general medical ward. So the background for this, quality of care is the extent to which a health service increases the likelihood of desired health outcome. And hospital administration already has means in place. There is a quality management cell, there are objective measures, there are benchmarks by which we compare our care to say that this is quality care or not. But quality of care or quality care may mean different things to different people. For a patient, it may mean affordable care that works. For a doctor, it may mean care which is as per the established standard of care or as per guidelines and with the latest technology. For an administrator, it may mean efficient and cost-effective care. There can be a disparity between the clinical indicators of care and perceived quality of care, and both are important because perceived quality of care is what will drive the uptake of the healthcare resource. So if a patient thinks that the quality of care in this hospital is good, which may be different from the clinical indicator, they're more likely to come back and access this healthcare. Physicians' perception of their patients' health beliefs and the patient's health beliefs has been demonstrated in other studies to not always concur. So physician may feel that, okay, I have explained everything to my patient understands everything about their disease, but the patient's health belief may be a little different. Their understanding of their illness and of the treatment that is going on may be different from what the physician believes it to be. Patient satisfaction is not only driven by the real hard things, the infrastructure, the medicines that are available, what the hospital building looks like, but it also is driven by soft things like the relationship that they have with the healthcare provider, by the level of trust they have in the healthcare provider. And studies have shown that patient satisfaction and job satisfaction in nurses seems to correlate. And a good doctor-patient relationship can also lead to job satisfaction in doctors. I'm trying to bring out that patient satisfaction and job satisfaction in the healthcare providers are connected, which is why we wanted to look at how the patients look at see the healthcare in the ward, think that the healthcare in the ward is. So the objectives of the study were to explore the perceptions of the patients toward the care in only the general medical wards and the healthcare providers' perception of care, which is, I understand it's a vague sort of thing, but as we go into the results, I'll come to a little more substantial things as to what I mean. So the methodology, it's a qualitative study again. I conducted semi-structured interviews, which were again derived from conceptual frameworks. So the conceptual framework was based on literature and based on my personal view of what could affect the healthcare provider's perspective and what could affect the patient's perspective, I thought of, okay, these might be the domains in it. And I developed interview guides. Then I use these interview guides to go ahead and interview. So I interviewed 10 patients and 10 doctors, and I did one focus group discussion with 12 staff nurses from the ward. We translated this data because the patient data was in languages other than English. We transcribed it to English, and then the coding and the rest of the analysis was done in the NVivo software. And similar to Sakshi's study, this is a thematic analytical approach. So I'll just go through the steps of the thematic analytical approach, and to just reiterate that this is, even though it sounds a little vague and not as numerical, and this is not the statistical things that we're used to, it does have a system in place. So after transcribing all these interviews and the focus group discussion, I reread the data again and again to gain familiarity. Then I started coding the interviews. Coding is to identify certain domains, certain aspects about the care that are coming up again and again, or something that seems of importance. And after doing this coding in NVivo, one of my guides, who's a social scientist and has experience in this type of research, reviewed my codes and gave corrections on that. Then a code book was created with the codes that came up in the initial interviews, and then this code book was used on other interviews. Then again, as I went through other interviews, if any more codes came up, then those were included in the code book. Then I categorized the codes into different categories, to say, and then tried to club these into different themes. We revised the themes to ensure that there was coherence, to ensure that I had supporting data. So I had actually people said this, to go back and say that, okay, this is my theme. I should have evidence that somebody said this, and to make sure that all the relevant data was included, and selected the key codes. I'd like to come to the results. So just going over the participant characteristics, the 10 patients, 5 were men and 5 were women. The sampling here was also purposive, but tried to have a variation, which is called maximum variation sampling. So I tried to have men and women patients of different socioeconomic classes. Here, the median age was 50 years, and the median duration of illness before they came to the hospital was very variable, between a week to 6 months. Then within the doctors, there were 6 women doctors and 4 men doctors. I tried to include both residents and consultants to get different viewpoints. 5 residents and 5 consultants were included. And within the consultants also, there were different levels. So there were assistant professors and senior residents. Median age here was 28, which just happens to be the time we become registrars and consultants. I had 12 female staff nurses. Median age was 29, and the focus group discussion took 108 minutes. I only had female staff nurses, unfortunately, as ward nurses were more women than men, and it just so happened that the ones who came for participation were women. So the themes that came at the end of all of this, when we look at the patient perception, we look at why did they choose CMC to come for their care? What is their understanding of the illness and their goals of treatment? How do they perceive the relationship with their healthcare provider? How do they perceive the ward environment and facilities? And what do they think about the cost of care? When we come to the healthcare provider's perception, we look at the doctor's perception of the patient's understanding of illness, and we compare with what the patients understood and how the doctors thought how good the patient's understanding was. The healthcare provider's perception of the healthcare team, the members, and whether the informal caregivers had a role to play. The healthcare provider's perception of the communication in the ward in between with the patients, in between the healthcare providers, in between teams and within a team. We also asked them what they thought about the treatment and administration in our general ward, and the infrastructure and facilities, and of course the cost of care. So I'd like to go through the results with some illustrative quotes. So CMC as the chosen center of care, all of the study participants in my study had come by referral or for second opinion, and they quoted prior experience which was positive and the reputation of hospital as why they came to CMC. When we spoke to them about their awareness and understanding of the illness, the doctors felt that patients' understanding of illness, prognosis, treatment, and treatment cost is important. They said it's important. However, the patients in the study had limited awareness and understanding of their illness. Sometimes the patients and the family members said that, don't tell me what is happening, I don't want to know, and tell the relative. Or the family would say, don't tell the patient what the patient has, tell me. This is what the doctor said. One patient said, treatment is being done for stomach. If something is told, I start crying. My son has said, if you tell Papa that this has happened, that has happened, he will panic. So till now, I don't have any clear information. So this is the patient saying that he doesn't know about the illness, and the son has instructed the team not to inform him. Another patient who seemed to be very aware of his illness also said, 3 days back, I became breathless in the midnight. There are 2 reasons. He knew that there is kidney disease and other is heart failure. So on the other hand, this other patient who is from an upper middle class seemed to be very aware of his illness. So there are both of these types of patients are there in the ward. Doctors said that they face challenges in fully informing a patient because of the cultural norm, where we tend to speak more to the family rather than to the patient and ask their opinion. Even though all the doctors agreed that the ideal way would be to speak to the patient directly and inform them and get their input. So one of the senior residents said, I would want to ask the patient whether he wants to know the diagnosis. Does he want to know? How much does he want to know? I want to say all of those things. But then in our situation, I would involve the family also in that decision. So the family, the closest member, I'll ask them as well before proceeding to inform the patient. When we speak about what the patient's expectation from treatment were, a lot of the patients with their limited understanding of illness just said they wanted to go back to their routine life. Some patients had specific expectations about what the treatment would be. But one patient who's 26-year-old male from a lower middle class said, nowadays I'm spending my life in the hospital. It would be nice if I'm given tablet monthly once I can come and seek the treatment. So his aim was to get out of the hospital and go back to his life. Coming to the patient-provider relationships, patients themselves valued conversation with the doctor highly. But some patients said that they did not have chance or time to speak to the doctor in the way they wanted. One man, this is the same patient in the previous quote. If I have any doubts, I talk to the doctor to clear it. I'm so comfortable with the doctor other than nobody else. The doctor talking to us is their main quality. Without talking to us and giving medicine is not sense. When the doctor speaks to the patients, it reduces the sickness. Ironically, the same patient didn't know much about his illness and his only aim was, okay, I need to go home. However, at least he found that he could speak to his doctor freely. This was in contrast to another patient who was from an upper lower class, so a 36-year-old gentleman. She, who was the doctor, is not alone. 4 or 5 doctors are with her. I cannot speak very openly every time and also not with madam. She has not much time. There are other patients too, not only me, there are other patients too. So this gentleman who was from West Bengal found that he did not get a chance to speak to the doctor to his satisfaction. Some patients were also not familiar with who is in the healthcare team. The nurses also pointed this out, and that patient and family didn't know who is the treating doctor. So one patient said, everybody is visiting and seeing us. We cannot say who all they are. There are many doctors. In the morning also, many doctors came. So the patients may not know who exactly is who in the treating team. One of the nurses said, sometimes the patient's relatives also don't know which doctor is seeing the patient. Relatives keep on saying, they don't know, nobody is seeing, even though already seen. Again, they will say no doctors came. So the patients, I think, did not always know who is in the healthcare team when they have been seen by the doctor. Coming to the patient's relationship with the nurses, some patients found that the nurses' responsiveness was lacking, but they acknowledged the nurses had a busy duty. Some patients were very happy with the nursing care. So one patient said, but when the nurses called, they don't come soon. I tried to call doctor, but they don't listen. Another patient said, every nurse, every caretaker, they are so responsible about their duties. I never called 2 times for help. So the patient's experience with the nurses does vary within the ward. When we talk about communication with patients and what the doctors feel, how important it is and the challenges they face, the doctors said that a good rapport with patients is important, and that if they could assure the patients of their sincerity, then if there is a bad outcome, then the relatives are more likely to be accepting of that as something that came up. But they said that time constraints, language differences, doctors' interpersonal skills, patient's passivity, in the patient not wanting to talk much about the illness, communication indirectly in the communication with the relative instead of with the patient, these are the challenges that impede the doctor having a good relationship, a good communication with the patient. Nurses faced impatience and antagonism from patients and their families regularly, but they said that if they had a chance to spend more time with the patient, then that improved their relationship. They also, again, encountered language barriers and resolved them through ad hoc interpreters, the other patient relatives or other patient who spoke English and the other patient's language. However, they said that when we asked them, would you like language lessons? They said it's not feasible. Extra time we can't spend on language classes. We have family and we have work at home. So this is something difficult. We need to figure out how to get beyond this language barrier. When we talk about relationships between the healthcare professionals, doctors and nurses, they recognize that not just them, but the attendants, housekeeping staff are also part of the health care team. Doctors consider nurses equally important, but they acknowledge that there is a hierarchical system within the team. One of the doctors said, medical team usually does not take it very well when nurses try to give their input into patient's care. We see nurses as people who are only there to execute orders and not the other way around. Some of the nurses, even though doctors said that yes, nurses are part of the team, some of the nurses did not experience this. And junior staff especially were emotionally impacted when there were conflicts with doctors. So one of the nurses said, in our ward, they're shouting, so many doctors, they're fighting with us also, because of you only it is not done. They're giving complaint to nursing service, they will go to charge nurse, and in front of the patient relative, they will fight with us. So this was one of the grievances that the nurses brought up. But another nurse was more understanding, and she felt that they're not shouting and all. They won't shout much or anything. They want to complete the procedure. So they're asking, come on, sister, it is getting late, please hurry. But we are not getting targeted shouting. However, I think we need to remember that there are other negative experience also exists. The nurses spoke about poor and untimely communication from doctors to nurses about procedures that were planned for the patient. Any new medication or treatment orders were written and not informed to nurses. And they also found that it was difficult to communicate with and give any input from their side or to question any doctor's decisions. One nurse said, that which in context was whether the nurse can question the doctor's decision also depends on the doctors. Some doctors we're not able to say. They will show face. Sister, I only will decide. Then one nurse said that if 2 o'clock there is bone marrow, staff will not know. They are writing prescription and all. Only when the technician comes, we come to know that there is a procedure. So there, even though doctors acknowledge that, okay, nurses are part of the team, there is definitely a gap in communication between the doctors and nurses. When we come to decision making for the patients, everybody, all the healthcare providers felt that decisions were primarily within the doctor's responsibility, residents and consultants handling the day-to-day decisions. Nurses' inputs were sometimes included and appreciated, but like we saw in the previous code, it was not universally appreciated. Coming to the patient's role in the decision making, doctors said that they had minimal involvement in the treatment decision making because of limited information and education. But patient participated when there was equipoise cost. So when this treatment or that treatment and only cost is the issue, that is when patients were participating in the decision. And patients' relatives actually played a more significant role. So one doctor said, it's actually usually us choosing the best option that we think and then asking the patient for permission to go ahead. I don't know how practical it is to perform shared decision making in each and every medical decision in a setting like ours. And another doctor highlighted about lack of patient autonomy in the sense that if they're from the socially, economically weak sector, we do not give them all the information that they need to make a good decision. If it is a woman, we don't ask her directly. We tend to talk to her husband or a father right in front of our eyes. This was brought up by a resident. When we talk about how we are making decisions and whether our decisions are evidence-based, doctors in the ward, especially the residents, valued evidence-based medicine and the importance given to evidence-based medicine in the ward. And they spoke about how CMEs, journal clubs, and online resources were useful for them to make evidence-based decisions. But they also spoke about how adapting this to a socioeconomic context was important. One resident said that one thing I like is that they keep giving us journal clubs, even though we don't like it about time constraints, but it helps us in being on top of the subject and knowing the latest evidence. So this was about the decision making, and next I'd like to come to the infrastructure. And patients that we spoke to were satisfied with cleanliness and privacy in the ward. Some patients said that navigation was difficult and their relatives were inconvenienced by going to pharmacy again and again. And they also spoke about the lack of beds for the caregivers in the ward. So one patient said, if you ask me to go to B ward, I cannot go alone because I'm confused about the building. If anybody doesn't know about the way, the security can guide us in respectful manner. And something that 1 or 2 patients brought up was that security was not always very nice to them. Another patient spoke about the lack of bed for the informal caregiver or the relative. Attender also wants a nice sleep, but this is what we didn't expect. Normally, attender stays means they used to sit only. Sitting itself, they feel very tired. The healthcare provider's perception of infrastructure said the healthcare provider said that manpower shortage was a main issue. Nurses said they faced challenges due to multiple sick patients in one shift, which allowed them which disallowed them from spending time with the patient. Shortages in attenders caused delays in shifting the patients and long waiting times for patient to come back. And there was delays in prescription filling and replacement of ward stock. So doctors spoke about how ward stock was not always available, and nurses said that it's because the doctors were not giving the prescriptions on time. Nurses spoke about how because they found there was a shortage of attenders and they were very anxious about getting the patient to procedure on time. We will be very scared of missing a procedure. We will be begging for the attender. It's all quite difficult. One registrar just said, how much can one registrar do? It's a bit out of context, but we were asking them about manpower, and that's the context. The doctors and nurses said that they felt the monitor numbers were inadequate. One nurse said, all patients need care, compulsory monitor, but we cannot connect, only 12 are there. But outer patients also we have to connect sometimes. Outer means not very stable, sick patients only. So outer patients, which are supposed to be stable patients, are also often sick patients and require monitoring, but they don't have equipment for that. Another infrastructure issue that came up, this study was done a few years ago, so things have changed since then. But one resident spoke about how the number of computer stations was inadequate. But this resident also pointed out that they were not bothered by it because they had workstation in their laptop, the app in their phone. So even with the less numbers, they were okay. However, the nurses said that if the doctor was using a computer station, they couldn't get access to it and they had to delay their computer work. That was about the infrastructure. And coming to cost of care, doctors seem to be aware of the direct and indirect medical and non-medical costs and said that investigations that we do and the duration stay were modifiable. And this doctor recognized that waiting time and indirect costs because of the waiting time were also contributing. Patients' opinion, affordability of care, and request for concession, according to the healthcare providers, seem to correspond to according to the patients, what the patients we looked at, one patient had insurance and the others who asked for concession seemed to be from a lower socioeconomic class. Healthcare providers felt that the cost of care is mid-range, but the lack of insurance still makes it very burdensome for patients. So the first quote from the doctor was that very few of our patients have any form of insurance, so they're paying out of pocket by borrowing money or selling possessions and land. Patient, however, who was from an upper middle class said that when you compare CMC with other hospitals, I say that CMC is less in terms of costs compared to other hospitals. Another patient from the lower middle class spoke about how she had to borrow money from relatives, neighbors, and friends and did not have a health card or insurance. When we spoke about subsidization of care, it was seen as doctors by a complex work, and doctors felt that it was probably better done by trained social workers. Age, baseline health condition, and reversibility of illness was considered as factors on deciding who receives a concession. And doctors said that they were uncertain whether this subsidy is reaching those who need it. Nurses said that patients may downplay their financial capacity to request concession, saying, well-to-do patient only getting concession. So I know these were a lot of results. I would just like to conclude them and compare it to what other studies have looked at, and I will just go into different themes. So when we speak about patient awareness and understanding, I think it came up that patients have a limited understanding of their illness, which was worse in those with low socioeconomic backgrounds. And this is because of health literacy, time constraints by the doctors, and paternalism in medicine, where we want to take the decisions and we don't take the patient's input as much. And these findings align with studies in countries, other low middle income countries in Africa, but also in a study in the United States where patient-doctor concordance was not excellent, and this issue is not exclusive to developing nations. Communication challenges are there between providers and patients, in between providers and doctors and nurses. And this is similar to, and another thing that nurses felt was that patients did not appreciate communication with them as much as they did with the doctors. And this is similar to the Q-tip study had found that doctor interaction was much more valued by patients than with nurses. Language barriers and time constraints have been found to be barriers in communication in another study in South India as well. Healthcare team dynamics and familiarity with healthcare team members seems to be inadequate in the ward. And between the doctors and nurses also find it difficult to question the doctor's opinions. The next part about decision making, different from the ICU study, I think here both the healthcare providers and patients recognize that the treatment decisions were mainly taken by the doctor and the relative rather than the patient. And this paternalism is, I think, a cultural factor. Like a culture is more to speak to the relative and rather than to the patient. In a study done in South India in 2018, this was only for cancer patients. the patients preferred physician to make the decision, and around 2/3 of them also involve family. So patients in general don't seem to want to make the decision themselves, but I think that should change. Coming to infrastructure and resources, the healthcare providers brought up shortage of monitoring equipment. There were comments about duty rooms and computer stations. Things have changed a little bit since the study was done. Absence of beds for caregivers and inconvenience in navigating and going again and again to pharmacy was something brought up by patients. Other studies in India have shown patients being unhappy with water quality, cleanliness, which did not come up in our study. Patients were happy with cleanliness and privacy in the ward. Something that came up about doctors in the US, there is a growing demand for duty rooms or doctors' lounges, which was something that the residents also spoke about in the study. They didn't have adequate bedding in the duty room. Coming to cost of care, this cost of care in our hospital was perceived as moderate, but it still remains unaffordable for poor patients who don't have insurance and have to sell assets even to afford this moderately expensive care. And whom to give concession on and who decides whom to give concession to is something that doctors find challenging. The limitations of my study is that it was a very broad research question. I was asking about everything to everybody, and I had a limited ability to explore one of these things in detail, but I think that can be done in a study going forward where any one of these issues, whether it be deciding cost or deciding about cost of care or patient education, can be studied in detail and further. I did not look at hospital stay. So whether my patient's poor understanding of illness and lack of familiarity with the health caregiver was just because they had just been admitted is something I didn't look at, and that was a limitation. Investigator bias. So I was a resident myself when I did the study, and I had my own opinions about the way the healthcare is and my own priorities. So that may have affected the way I came up with the interview guide and the way I interpreted these results. And it may have influenced the patient's openness with me when I spoke to them, even though I reassured them that my interview would not affect their care or cost of care. I could only speak to female nursing staff, and like sir pointed out, I only did one FGD, which may have been inadequate to capture the experiences of all the nurses. The general medical nursing pool is a big group. And the fact that I did focus group discussion after my interviews meant that things that emerged in the focus group discussion with the nurses facing challenges with communication with the doctor, I was not able to go back and speak to doctors about it because I had spoken to the doctors already. So this is something that again can be looked into. The doctor-nurse relationship is something that needs to be explored. So my recommendations coming out of this study, I'd like to divide it into first about staffing and support, training and education, and the infrastructure and resources, what can we do? So I think clinical assistants and social workers can be hired. They can help with documentation, prescriptions, organizing patient transfers. And this opens up time for doctors and maybe even nurses, if you take away the logistics, to spend time with the patient. We can assess the cost of this because I think other departments are already employing clinical assistants and social workers, and within medicine, some units have social workers. So whether this can be applied to all the units and whether clinical assistants can be something that we can afford and might help us is something we should look into. Another thing about staffing is that the nurses said that outer patients who are supposed to be stable are sick. So even though the nursing ratio is supposed to be a certain number of sick patients or number of stable patients, they end up having many sick patients and not able to spend time with patients, which affects their relationship and communication. So adequate nursing staffing has to be looked into. Coming to training and education, we have to train the doctors to prioritize the patients, communicating with the patient and involving the patient in healthcare. This may be my personal opinion that the patient needs to be more involved and more aware of their illness. But even if we free up the doctor's time by giving them a clinical assistant, they still have to take that time and put effort into educating the patient and asking what the patient wants. We also need to improve communication in between the healthcare workers. Perhaps training or communication workshops may be necessary for doctors. Adequate computer stations, I think this has improved, but still, if we are going to move to an inpatient EMR system, we may need more computers. I think a futon or bedding for the patient relative is something that has already been implemented in Ranipet campus, and it's not a recurrent in cost, and I think that is something that can be brought in. So thank you. I'd like to thank Tambu sir, Vignesh sir, and Medicine 5 for allowing us to present our thesis, and I'd like to have Katie sir.
Yeah. Thank you very much. No, I just want to comment that the issue of methodology remains the same. Other than that, yours has become very generalizability of your subject can improve if you separate out institution-specific issues separate from generalizable issues. You put everything is relevant, but you separate out the institution-specific one and present it in a different way. If you mix it up, you can't maybe I don't think publisher will take, because there are lots of institution-specific issues. Separate it out. And you can just summarize the institution-specific issues and generalizable issues as a separate topic. So that will be very good in it. Any questions on that?
Again, sir, this is a new area. We were not sure how a qualitative study in a ward would manage. And it was COVID time, and we were not sure what the findings would be. But again, hats off to Jahnavi. She took a lot of effort, went through the whole effort, and finding a private space in the ward to do these interviews was tough. Again, focus groups, we had to bring them to the CEU, all the nurses at one shot, and finish it off during COVID. So it was a bit tough. So again, hats off, Jahnavi. We should also thank Dr. Shubhakumar and Dr. Rani from Samarth, who are not here today, but they really put their heart and soul behind this. They came 3-4 times, taught them, took workshops, and then went through the results and helped them to come to the stage. So we owe them that. I just also want, yes, they are online, sir. So other thing is, I want just questions from also Dr. Kishore about the ICU, what he felt about the ICU part of it. Unfortunately, we couldn't hear from Peter. So maybe it'll be nice if we can get from Peter, Kishore, as well as Dr. Rani, and if they're online.
Sir, JVP sir, sir has posted comments, but if sir could unmute and offer sir's comments and questions, please, sir.
Am I heard?
Sure, sir.
Am I
I'll
heard?
read.
Are you able to hear me?
So sir has written, nurses generally do not give information on prognosis, as there are many people giving information to caregivers. That it can sometimes be conflicting or confusing to the families. This can also happen because of some differences in the information provided by the parent team, the ICU team, and social worker. That is one of sir's comments. And another question is, what was the single most important factor that influenced the choice of patients to come to CMC? Was it excellence of care or accessibility or cost? Did this come through in the interview? Sakshi.
I think the two things that came up was, one was they thought the cost of care was less compared to outside hospitals, and second thing was they had heard that the outcomes of patients were much better as compared to other things. So those two were the things that had come up as why they came to CMC.
Sir, any other comments, sir? Sir, any thoughts?
Can I have some
Thanks,
words? Can I have Dr. John speaking? Thanks, Jahnavi and Sakshi. It's nice that the physicians are taking so much interest in ICUs, and all because Kurien Thomas made the initial few studies where we could also collaborate. And regarding cost, I wanted two words to be heard. One is indebtedness, and the other is called catastrophic expenditure. These two issues are very much associated, and some of the things I saw it is covered. I'm sure all those things are also covered in the thesis. So it is good to.
KR, your sound is not coming through. What exactly do I can make it? Can you make it loud? Just say it in a few sentences. What do you want to ask?
Sir, sir has posted the opinion. I can read it out. Yeah, that's okay. What was the opinion on indebtedness? That's one.
Indebtedness.
And how many of the families were pushed down the poverty line, incurring expenses? How they raise money for the expenses? What was the overall subsidy by CMC?
But did they do that?
So that was done by a colleague who was looking into the health economics part of it.
Yeah. So that is a separate study which is not presented here, KR.
Okay. Thank you, and thanks for the team for taking up all these.
Yeah, thank you for presenting these studies. Just a general comment that when we say, what we consider excellence of care, I've seen that over the last 20 years itself, our opinion of what is excellence of care has changed. Initially, it was only academic, perhaps excellence or ability to do things as a first or being, somewhat having things that was not there in other places. That was the only thing that we would consider that was excellent care. And increasingly, we're looking at what it means to the patient and the family, and we're giving more importance to that. And I think that's a very good thing, that we realize that that's a core part of excellence. There's some other things. The social worker that the inclusion of a social worker in our interaction with patient families in the ICU has really helped. It's helped the patient families, and it has helped the caregivers. I mean, us as well. It's helped the nurses. It's helped all of us to understand what's going on. There's a better connect with the family. There's better family satisfaction, and because there's a limited amount of time that a doctor can spend with the family, the social worker kind of works like a surrogate in terms of the time that can be spent. And that really makes a lot of difference, because it's not only technical information that they need. Sometimes it's just someone to talk to from the team. The word social worker, of course, is a bit broad. Different social workers do different things in different units, but in our unit they work like counselors. So really, that's what we need, and that's really helped us. In terms of the interaction between healthcare providers, I think the ICU here has a very nice model of being the semi-open model, and I've been always fascinated by the way it seems to work without too many problems, given how both the unit and the ICU teams have to kind of concur on many things. And in spite of two kind of strong teams working on both sides, the number of times that there are actual conflicts is, I would say, very small. And I think we work together very well. And I like this model because compared to a closed model or a completely open model, this having both teams has proven very valuable in many patients. In the ideas that we've been able to bounce off each other, and it has helped many patients. So I think that's a very nice model that we have. And of course, diplomacy is part of being and working in the ICU, because we have to deal with lots of people in the healthcare team, much more than in the ward. And also we have to deal with different units, consults, primary units. So learning how to deal with other healthcare providers is a very core part of being in the ICU. And thanks for bringing up some issues that you said. We could look at some of those. Staff shortages, I'm sure that is there all the time. And there's a changing landscape in terms of the type of doctors that could work in the ICU. We are finding it more and more difficult to find non-PG workforce, because there is no incentive for them to really work in a tough environment like the ICU. They'd rather be in some light work and study in this current environment. So that group is kind of shrinking. And instead, we are more and more finding people who are post-MD, who are just post-DM, or who are working as senior residents or senior registrars. That group kind of is expanding. So there's kind of a change in the demographic there as well. Nurse shortages, of course, have been an eternal problem, and I don't think that will be solved anytime soon. I think the visitors policy has been reviewed. There's been some changes, I think, in line with some of the feedback that you were saying. The waiting facility, well, definitely it's those are limitations of the building we are in, and hopefully this campus reorganization will solve that. But definitely better now than it was, where the families were living in the corridor, and now at least there's an additional space that has been created, and JVP was able to push the engineering department to actually do that, which they thought was not possible. But yes, so those are ways in which the actual building or infrastructure can also influence patient and doctor satisfaction. And of course, we learned from that, and the Ranipet building is, of course, a testament to that. Hopefully, that will be enough in the times to come. Yeah, thank you.
One last comment, Jahnavi and Sakshi, there's something called as member check-in to improve validity in a qualitative study, which if you're doing in an institution and you're trying to this thing is to look back to the person who participated and after you've done your codes and said, have you interpreted it correct? So I don't know if that was part of it, but it would improve your validity. I know in your methodology that didn't come out, but that's something that can be easily done in an institution like this. I have one last question to Dr. Katie.
We can do that, sir. One of the process of this data triangulation is also to do a dissemination meeting, see what we have concluded from the interviews is the same as what they were trying to do. So we thought that this meeting also may help with that. And yes, ma'am, we can reach out to the participants because they're all here to see if we've interpreted their data correctly.
So one last question to you. Can we sing happy birthday? Can everyone, it's Dr. Ramya and Dr. Katie's birthday. So,
Can we give Jahnavi and Sakshi a hand? Yes.